Most people in the United States are planning to get a COVID-19 vaccine, but some may want more information before choosing to get vaccinated. Be prepared to answer questions about how the vaccines are developed and authorized. And remember to emphasize that they are safe and effective. People may have previous experiences that affect their trust and confidence in the health system.
As a running back, I took a lot of hits on the field, but I didn't want to get hit by COVID, so I got vaccinated. Don't take the hit. Get vaccinated.
I'm getting the vaccine to continue my culture.
So that I could dance another day.
So I don't have to lose another brother. Sleeves up, Nola.
Sleeves up, Nola.
Sleeves up, Nola.
By taking time to listen to their concerns and answer their questions, we can help them become confident in their decision to be vaccinated. There are resources to support these efforts. By providing communities, practitioners, and vaccination partners with the information they need to have essential vaccine conversations, we can build a culture of trust in vaccination.
Good morning. And first of all, I'd like to thank Dr. Besser for moderating the federal leadership panel and to the panelists for updating us on the federal government's progress towards a safe, effective, and equitable vaccine program. My name is Dr. Leandris LaBird, and I am the Chief Health Equity Officer for CDC's COVID-19 response. Today, we have a rich tapestry of people who have come together for the sole purpose of getting COVID-19 vaccines into people's arms quickly, safely, and equitably. You join us from every state, Washington, D.C., 7 U.S. territories and freely associated states, and over 125 tribal nations or organizations. We thank you for joining us and thank all of you for your tireless work in the past year fighting this pandemic. We also want to thank you in advance for your participation in the work that's still to come. While we have a growing supply of safe and effective COVID-19 vaccines, and we see progress being made every day in getting people vaccinated, we still have a long way to go. Building trust and confidence in COVID-19 vaccines is essential, especially when it comes to vaccinating people equitably. We have more work to do to successfully reach many of the people who have been disproportionately impacted by COVID-19. Over the course of this forum, 109 experts from across 31 states and tribes will share their stories of how they have been contributing to this historic vaccination effort. They will highlight their challenges and lessons learned. This work has not been easy, but we are confident that their stories can provide everyone listening with practical ideas on what you can do in your organization to bring COVID-19 vaccination to all communities. I cannot think of a more important aspect of ending this pandemic than building trust in the vaccine, but also in the providers who will be administering the vaccine, and in the national, state, and local leaders who are working every day with communities to foster confidence in all aspects of our efforts to protect people, particularly those who are at increased risk for severe illness. As I interact with family, friends, and with members of my own community, everyone is talking about COVID-19 vaccines, and they're grappling with making a decision about whether to get it or to wait. Invariably, I am asked what I think about getting the vaccine or to validate or clarify something people have heard on TV or in their daily interactions with friends, with family members, as well as with other community members. What I tell them when they ask is that based on the available science, I think getting vaccinated is a good idea, and that I myself plan to be vaccinated as soon as possible. These experiences have underscored to me that there are so many questions and a real hunger for accurate information in communities across the country. This forum comes at the perfect time as we organize to meet the needs of communities across the country for reliable information they can trust and act upon. I am so excited to be part of the National Forum on COVID-19 vaccine and to welcome you to our first plenary session focused on the importance of trust and vaccine confidence. Today, we begin our plenary by hearing from some national experts on the importance of addressing systemic health and social inequities, the safety and effectiveness of COVID-19 vaccines, and the work we need to do to build confidence in all communities. Our first speaker is Dr. Cameron Webb, who is the Senior Policy Advisor for Equity for the White House COVID-19 response team. Dr. Webb, thank you for joining us today.
Thank you so much for having me, and it's exciting to be here, Dr. LeBird, to join into this really important conversation. And I'll start off by saying this. Long before 33 days ago, when I joined this Biden-Harris administration as a senior policy advisor for equity on the COVID response team, I was a practicing physician. Work as an internal medicine doctor, a hospitalist at the University of Virginia in Central Virginia. It's a community that I'm passionate about, that I love and I care deeply about. It's a community that's kind of nestled in the Blue Ridge Mountains. It's known for its major university and even its kind of budding industry around wineries and breweries. It's also known for a really terrible moment in 2017, the Unite the Right rally, which really highlighted challenges with race and dynamics here in our nation. But just the same, this is a community that I'm incredibly invested in and that I've continued to be over the years. About a year ago, we were planning as a healthcare system for this coronavirus pandemic. And one of the things that stood out to me was that we knew it was going to disproportionately impact different communities. Here in Charlottesville, we're pretty attuned to some of the challenges with regard to race and ethnicity, the challenges with regard to structural inequality and systemic racism, and how they coalesce to create difficulties, whether it's in education or access to food systems, whether it's in transportation dynamics, and yes, even in our healthcare systems. Shortly after COVID arrived here in Central Virginia and in the United States more broadly, we realized those potential inequities were cropping up. We knew that this was going to be a challenge, and yet here it was. One of the first things that folks started to do is step up in communities all over this country. They made masks for each other. We made sure that we were pushing for people to have access to testing. We pushed for a stronger data infrastructure nationally to make sure that we knew who was getting access to testing and who could find out whether or not they had COVID. But early on, it was pretty clear. COVID was impacting different communities differently. There were groups that were at greater risk, whether it was older adults or individuals who live in congregate living settings, folks who have a burden of chronic disease. When I walked into the hospital and I work on the coronavirus unit, what I saw were people who were disproportionately Black and brown, people who were disproportionately essential workers, and people who disproportionately were not given the opportunities and the access to our healthcare system that they so sorely need. Now, fast forward a year later, and we hit a grim milestone. 500,000 individuals in this country who died from coronavirus. But here's the thing, that impact has been disproportionate. We've seen that Black individuals here in the United States are 1.9 times more likely to die from COVID. For Latino individuals, 2.3 times more likely. Native Americans and Alaskan Natives, 2.4 times more likely. We've continued to see anti-Asian sentiment that is really challenging the dynamics that we have in our communities. No matter what community you're talking about, COVID is hitting different communities differently. That disproportionate impact has to be a part of our strategy and has to be a part of our solution. And so as we define equity, the first thing we say is equity has to be the idea that no matter who you are, no matter where you are, you have the opportunity to get and stay healthy with regard to this coronavirus pandemic. And that plays out through your access to healthcare systems, but also your access to therapeutics, and yes, this really critically important vaccine. Now, you heard in the previous session, my colleague Josh Peck talk about the 3 C's of vaccine hesitancy. That's a term that's now become really popularized in kind of communities all over the country. But when you break it down, there's those dynamics of complacency, of convenience, and of confidence. And yes, we know there are challenges with complacency. Some people don't think it's necessary to get the vaccine, but we do know that it causes severe health problems. Yes, there are issues with convenience, and I'll talk about that in a second because we know there aren't enough venues for vaccination everywhere. There's not enough vaccine in communities everywhere. So we have to make sure that we're really ramping up the availability of vaccine for people no matter where they are. But it's in that confidence space that we really find a lot of the unique challenges. We know that there are challenges that folks have with regard to the safety and the efficacy that are rooted in real experiences of folks having access to treatments that weren't necessarily safe or efficacious, being told to take something that didn't really serve them well. We know that one of the confidence issues is confidence in the systems that deliver these vaccines, and that include some reliability and competence of the health services and those health professionals. But realistically, here in these United States, that's been a problem for a very long time. Going back to the so-called slave health deficit, where there were individuals experimenting on Black bodies, or whether you fast forward to W.E.B. Du Bois and the Philadelphia Negro identifying and articulating those differences in mortality by race and ethnicity in Philadelphia. Or moving forward, when Dr. King said of all the forms of inequality, the injustice in healthcare is the most shocking and inhuman. 20 years later, when the Secretary of Health and Human Services issued a report on Black and minority health that showed the dramatic disparities in our healthcare system. And then, 17 years after that, when the Institutes of Medicine issued a report, Unequal Treatment, that really highlighted the role of provider bias. We have more than enough evidence to know that our system has been perpetuating unequal treatment on our populations, not just by race and ethnicity, but also for rural communities that have been so often left behind. So that lack of confidence in the system is a very real thing. And then finally, the lack of confidence in the motivations of policymakers. We've talked about how important it is to get politics out of this process of getting vaccine to folks. People are going to be more confident if they know why it is we want them vaccinated. And the answer is simple. It's to save lives. I want to close by saying this. The Biden-Harris administration, it came in with a different mentality. You've heard already this morning the focus on equity in our vaccine rollout efforts. And that's a very sincere focus. The reason why we're focusing on equity is that you cannot have a successful vaccination campaign in the United States with this coronavirus pandemic without equity. Absent equity, the whole thing falls apart because this virus, it doesn't care your race, color, or creed, your geography. It doesn't care if you live in an urban community or a rural community. It knows that it's going to exploit every crack in our society's fibers. And so we know that equity is our path forward. We have a great leader in Dr. Nunez Smith, who's leading up as the coordinator for equity on the White House COVID response team, but who's also chairing a COVID health equity task force. We have a great team that's focused on getting this work done, getting recommendations, listening to communities all over. And I'll close by saying this week, we're leading a large stakeholder engagement effort, really listening to communities all over the country, getting your insights to know exactly what we can do to answer your questions. Trust is earned. It's not just given blindly. And we know that in communities that have been disproportionately impacted more than anyone else. So we look forward to talking with you this morning through these next 3 days. Glad that you're joining us. And we're hopeful that after this, you can help us spread the word about why people should have a little more trust in this vaccine. Thank you.
Thank you so much, Dr. Webb. We have an opportunity, and we certainly agree, to redouble all of our efforts to eliminate largely preventable health disparities. And so it's my great pleasure to now introduce an amazing leader in vaccine research, Dr. Kizzmekia Corbett. Dr. Corbett is the scientific lead for the coronavirus vaccines and immunopathogenesis team at the National Institutes of Health. Dr. Corbett, thank you for being part of the Vaccine Forum.
Thank you so much for having me. It is an absolute pleasure to have been invited today, and particularly a pleasure to dial back actually what the context of what we're talking about today is, really to the science and the onset of the work that we've done at the National Institutes of Health in the Vaccine Research Center, where I am a research fellow under the direction of Dr. Barney Graham. So I've worked at the NIH, at the NIAID for the last 6 years. And we've been so invested in pandemic preparedness, particularly around coronaviruses, that we studied coronaviruses for the last 6 years. And actually, even prior to me getting to the Vaccine Research Center, to really fundamentally understand how to make a really good vaccine against coronaviruses. Our work specifically with the team that I lead, is in the preclinical development. So that is before the vaccine gets to humans in the clinic, even before it gets to a phase 1 clinical trial. And I know that there are questions all encompassing from all spectrums, whether it be citizens, physicians, et cetera, that have a question about the speed of the COVID-19 vaccine development. And so what I plan to do today for my 5 minutes is to just briefly lay the landscape of how rapid development of a safe and effective COVID-19 mRNA vaccine was made possible, and partly due with our previous work and work of other laboratories and institutions from all over the globe over previous years. So it is notable that vaccine development often takes several years. That is from point A to point Z. That is from the concept of the vaccine design all the way to the point at which it is approved for general human use. One key accomplishment of the current COVID-19 vaccines is that this timeline was shortened, but no integrity was lost. The shortening of this timeline was due to several factors, and I'll just, for brevity here, name a few. The first of which we must acknowledge, is that the vaccine development efforts were coordinated across institutions and companies and otherwise. And then secondly, there was extensive work on MERS coronaviruses and other coronaviruses that really set the stage for our fundamental scientific understanding. For years, we and other researchers have garnered enough knowledge around the coronavirus vaccine development, particularly just zoning in on one protein. So I know that everyone is generally used to thinking about vaccines as inactivated viruses. So those are viruses that can't really infect a person, but can trigger an immune response enough so that if a person comes in contact with the virus later, that they're protected. In this case, we zone in on viruses, and for the last several years, studied that protein called the spike protein in such detail that we were able to understand how to make a really good vaccine from it. And secondly, how your body makes an immune response to it. That level of detail that we had really fueled our understanding for the current coronavirus that is causing COVID-19 disease, the virus named SARS-CoV-2. It is interesting because just as we think of ourselves and our families, we have brothers, we have sisters, we have cousins, coronaviruses and other viruses also have families. So the MERS coronavirus that we studied in so much detail over the last several years is, you could think of as a cousin to the current SARS-CoV-2. So the knowledge that we gained from understanding with MERS coronavirus enabled us to really translate that in the onset of this pandemic. Let's talk about the onset of this pandemic. Around the latter parts of 2019, there was a mysterious illness that was a respiratory illness in China. it became aware to us that it was a coronavirus. And around January the 10th, the sequences of that coronavirus was released. Over and over, we have said we went into a phase 1 clinical trial in only 66 days. And I know that seems like a very short time, but it is only because of the years of previous preclinical testing and an established collaboration with the company Moderna that really made that possible. So we knew all that we needed to know about spike protein, and Moderna had this beautiful platform called the messenger RNA platform, whereby they can deliver therapeutics to the body. Messenger RNA allowed for us to deliver just the coronavirus spike protein to people safely and effectively, and really allow your body to make a really robust and high-level immune response to that protein that in turn prevents your body from getting virus infection and COVID-19 disease later. Aside from the start of the phase 1 clinical trial, there are several key steps that suggested that the vaccine, importantly, we knew, particularly under my direction with the preclinical testing, that the vaccine was safe and created a really good immune response in animals such as mice and monkeys prior to ever testing it in a human. Second of note is that even with the phase 1 clinical trial, it is testing in only a small amount of people to really and firstly assess the safety of the vaccine. Noting that here, as we sit here on February the 22nd, that the first phase 1 clinical trials for the messenger mRNA vaccine started last year in March. And so we are about a year into our understanding of the safety profile of these vaccines. It is that each of the phases of clinical trial builds upon each other. So just as I talked about the phase 1 clinical trial starting as a result of data that we understood in animals, phase 2 clinical trials are informed by the phase 1 and so forth until you get to the phase 3 clinical trial where you get the 90-95% efficacy that we've all heard about. So it is important to note that while it is rapid, this process of vaccine development is systematic and without any sacrifice in any of the steps, whether it be on the preclinical side, from which I led, or through the phases of the clinical trials that have been moved thereafter. The scientific integrity was at the forefront of all of this vaccine development, as it has been for vaccine development previously, albeit more rapid in this case, not only out of necessity and dire need, as we are in the middle of a pandemic, but also because of technological advances that have gotten us to this point. And with that, I'll close. Thank you so much to the CDC for extending this invitation. And of course, thank you to the citizens of this country for caring enough about your health and the health of your communities to tune in to this great vaccine forum.
Thank you so much, Dr. Corbett, and thank you for helping all of us to better understand both the development of the vaccine, how it works, and just reassuring us that it's safe as well as effective. So I'd like to move on to our next speaker. Building vaccine confidence, especially in communities that have been disproportionately affected by COVID-19, will require tremendous effort. Building vaccine confidence requires commitment as well as cooperation. And our next guest is someone who is on the front lines and doing this work. Ms. Lisa Sherman is the CEO of the Ad Council and has joined us today to highlight the research-based insights gained during this pandemic, and specifically from the collaboration between the Ad Council and the COVID Collaborators Vaccine Education Initiative. Thank you for joining us, Ms. Sherman.
Thank you, everyone. Thank you for having me. I would like to start by having a big thank you to the CDC for inviting me to be here today to share a little bit about the communications efforts of the Ad Council and our partners as we undertake this effort to combat vaccine hesitancy. I really don't think it's an understatement or an overstatement to say that this is the biggest issue of our lifetime. And Because of that, we felt it was critical that we meet this moment with the largest public education effort in our history. You know, the Ad Council's ability to quickly stand up coordinated public education efforts at scale is truly needed now more than ever. And to help us do that, this fall we were honored to join forces with the COVID Collaborative, which is a truly extraordinary organization made up of bipartisan leaders in public health, education, and the business community. The collaborative includes current and former governors, CDC commissioners, FDA commissioners, policy advisors, business leaders, and so many more. Now, our first task was to conduct extensive research to understand the behaviors and the mindsets of consumers who are vaccine hesitant. We conducted in-depth qualitative and quantitative research across all of the relevant target audiences. And the results were very telling. We learned that 30% of the American public is already fully committed to taking the vaccine when it's available to them, and about 15% are fully resistant. We know, of course, as of today, approximately 13% have already been vaccinated. So we see our opportunity as residing in the middle 40% of the population who frankly are taking a wait and see attitude, and they're seeking more information to address their concerns. They're looking for real world evidence that the benefits of vaccination are going to outweigh the perceived risks. Now, when you shift, the mindset shift, if you look across different populations, when we evaluate adoption by demographic, Black and Hispanic populations, who we know, and as you've heard already this morning, have been disproportionately affected by COVID, and understandably have distrust of our medical systems due to systematic healthcare inequities. And so they're more skeptical than their white counterparts. Research has also shown that people's hesitancy across demographics is driven by 4 key areas where information deficits and misinformation exist. These include concerns about safety and side effects, the speed of the clinical development process, distrust in the political and economic motives of the government and corporations, and established and novel conspiracy theories involving vaccines. Through extensive message testing, we have gained rich insight on which types of language and messaging are motivating to this hesitant audience. These learnings include a few things. First, we must acknowledge their concerns. We need to make it clear to Americans that it's okay to have questions about vaccinations. It makes sense, and we can help them get the answers. Secondly, we must highlight those moments of human connection that people are missing the most. Visiting family for the holidays, going out to dinner with close friends, getting kids back to school. These are all broadly relatable and the most missed across all audiences. Third, we must put an emphasis on the vaccine helping to protect themselves and their families. And finally, we must engage with an inviting and respectful tone. We really need to avoid the negative reminders of what a difficult year it's been and resist guilting our audiences, telling them that this is the only right thing to do. So how are we going to do all this? What I'd like to do now is take you through an overview of some of the guiding principles of this initiative. Together, we're going to launch a unified, coordinated communications campaign, which will allow us to have exponentially more impact than any sort of a patchwork response would. Under this very big tent, we will bring together the top creative, tech, and media talent across the public and private sectors, and ensuring that we're working together with a cohesive and impactful messaging platform. We will then extend that messaging to communities across the country at significant scale. Importantly, we will be activating an aggressive ground game as well as an air game that will allow us to go broad and deep. So in addition to our national strategic media placements, along with PR and social media, we will have significant local presence. To accomplish this, we will be partnering with nonprofit, community, and faith-based organizations and building large coalitions across multiple audience segments. And while coordination is key, we know that this is not a one-size-fits-all proposition. We're envisioning multiple distinct campaigns to reach different audiences, especially communities of color, where, as you've just heard and seen, we are seeing higher levels of hesitancy. We also know that we must leverage trusted messengers. The issue of hesitancy is complicated and it's quite nuanced. They can be everyone from your local pharmacist, to your doctor, to your minister. These are trusted voices who can help educate people to make empowered decisions for themselves and their families. Messengers can be athletes and artists, and others who would be critical to ensuring that our messaging reaches diverse communities in culturally relevant ways. We'll also continue to coordinate closely with the CDC and HHS and the Biden administration. CDC and HHS will be providing scientific review for all of our content, and we're already finding ways to complement the work that they're doing. This will be the largest, most important national education effort of our time. And I know that by working together to educate and inform the American public, we will soon see better days. So I'd like to thank all of you who have already contributed so much, and I look forward to working with all of you in the days, the weeks, and the months ahead. Thank you.
And thank you, Ms. Sherman, for your presentation and all of the information that you shared with us. I am now going to turn the forum over to Dr. Julie Morita, who is the Executive Vice President of the Robert Wood Johnson Foundation, where she oversees programming, policy, research, and communications activities. Dr. Morita will moderate our panel focused on telling the stories of select promising practices to empower healthcare workers, to combat misinformation, and engage communities as we strive to build trust and vaccine confidence. Dr. Morita?
I'm so glad to be joining this national forum today and moderating this important conversation on vaccinating with confidence. I know we are all eager to hear about some promising real-world practices, so I'll just take a few minutes to get us off and running. First off, I want to say thanks to everyone attending, participating, and organizing this forum. Thank you for all you've been doing and will be doing to end this pandemic. You have given so much of yourselves for the sake of our nation and our communities. I'm so glad we have this opportunity to put our minds and collective energy together to build a healthier, more equitable future. At the Robert Wood Johnson Foundation, we have made health equity our central aim so that everyone in America has a fair and just opportunity for health and well-being. This work includes meaningful action toward racial justice. Prior to joining the foundation, I helped lead the Chicago Department of Public Health for nearly 2 decades, ultimately serving as commissioner. One of my main priorities in Chicago was reducing disparities in immunization coverage levels among children and adults. Sadly, as many of us all know all too well, the current COVID-19 crisis has deepened our nation's racial disparities, and ravage communities that have a long history of being underserved by our health system and society. Furthermore, recent research has shown that a significant number of people remain vaccine hesitant, including communities that have been hardest hit by the virus. While national statistics have painted a broad picture of the vaccine response, we also know that effective, sustainable change can happen and is happening at the local level. That's why I'm eager to hear how our distinguished panelists are engaging with communities, empowering healthcare providers, and working to combat vaccine misinformation. Before we dive into our discussion, I want to briefly raise 2 points. First, I think it's important to distinguish between building vaccine confidence and earning vaccine confidence. Health officials, lawmakers, practitioners need to earn the trust of communities that have faced historic and ongoing discrimination and mistreatment. Their distrust is rooted in the very real disrespect they've experienced for generations, and it's not enough to say, just get over it. We have to honor the lived experiences of those we seek to serve. We need to understand the hurt and build new bonds by communicating clearly, consistently, and transparently. And the communication has to go 2 ways, not just talking, but really listening. Earning trust involves spending time with everyone, from faith leaders to community organizations to local business owners. And it involves healthcare providers speaking with patients and thinking about the barriers that might stand between their patients and vaccines. Second, we should remember that vaccine hesitancy is not monolithic. There are a range of reasons that are unique to people's history, their community, their experience with the healthcare system, and the barriers they may face accessing the vaccine. Some people are taking a wait and see approach, while others have deep-seated concerns about the vaccine, stemming from this nation's legacy and ongoing experience of structural racism. So earning confidence is going to require different approaches for different people. Based on my experience in public health, there are a couple of key elements to successfully earning trust. We need to empower healthcare personnel, and we need to work with community to be advocates, ambassadors, and trusted messengers, strategies that the CDC has also recommended. So now I'd like to turn to our panel to highlight promising practices and key learnings from their work at both the national and local levels. This first question is for Dr. Joe Smizer, who is the CEO of Public Good Projects. We know that misinformation threatens vaccine confidence. Can you describe your work to track and mitigate vaccine misinformation?
Sure. Thank you, Dr. Marita. Well, first, there's more misinformation circulating than ever before. And I think that's a good place to start from, is the scale of the challenge of what to do with it is absolutely enormous. And we've never been faced with information at this scale before in human history. Overwhelmingly, what we're seeing in our work, and we track misinformation about vaccines, but just health misinformation in general, is honest information seeking. People just looking for answers. And as we all know, there's a lot of confusion out there. What's in these vaccines? What's new about them? How are they tested? How was it done so fast? What are the side effects? When and where can I get them? And there are new questions every single day. Our dashboards light up every hour of every single day with new questions and new misinformation and new disinformation. But this intense thirst for information is being leveraged by individuals and organizations incentivized in some way to spread misinformation, intentionally or unintentionally. This can take the form of earnest attempts to help, but without perhaps knowing what true and what isn't. For example, people who share stories from fake news sites or posts from accounts that share conspiracy theories. Maybe they're just trying to inform the people who they are connected to, and they don't fully understand the ramifications of the spread of misinformation. And then, of course, it also includes what's called disinformation, which is misinformation spread with malicious intent. These individuals and organizations take the form of anti-vaccine groups, conspiracy groups, anti-government groups, white nationalist groups, and others. And And one of the challenges of the time that we're living in right now is that these groups are converging. They're using similar talking points and they're reaching different kinds of people in different ways, but with those similar talking points. There's so much information seeking right now. Everyone is searching with the means that they have at their disposal. And many people are finding as much misinformation as they're finding information. So what do we do about it? I think a lot of things. Public health needs to know what misinformation is circulating and how to respond to it. And we need to do that better as a field. But if there's one thing we've seen really clearly in the data around people and what information circulates in social networks, it's that the messenger matters as much or more than the message. What a friend, a neighbor, a coworker, a family member, a faith leader, or a community leader, or someone we just see ourselves reflected in on social media says matters a whole lot. So thank you, and I look forward to our discussion today.
Thank you, Dr. Smizer. Now I'd like to turn to Dr. Ernest Grant, President of the American Nurses Association. Empowering healthcare personnel is one pillar of CDC's Vaccinate with Confidence strategy. Can you talk about what can be done to increase vaccine confidence among nurses and some strategies that have worked?
Thank you, Dr. Morita. Since the beginning of COVID-19, the American Nurses Association, which represents the nation's 4.3 million registered nurses, has been advocating to ensure that the support and protection needed to care for patients and help our nation recover. Vaccinations play a very large role in protection and prevention. And of course, public awareness and education are essential when any new vaccine is introduced. With broad distribution and administration of COVID-19 vaccines underway, nurses must be informed and have a visible role in the rollout and education efforts. Nurses are not just experts to their patients, they're also trusted resources or a trusted source to their families, their friends, and others in the community. In October of last year, our data indicated that only a third of nurses were confident that they would receive the vaccine. However, we're seeing some positive movements. In the last survey that the American Nurses Foundation conducted, we're finding that a significant number of nurses have, in fact, been vaccinated. Many have already received both doses of the vaccine. And among those who have not been vaccinated, several indicated that they are eager to be vaccinated as soon as possible. Through our survey data and story collections, we've been able to better understand what resources are needed to be developed based on actual concerns and questions from nurses, some of whom may have been initially hesitant to receive the COVID-19 vaccine. And we have found that supplying evidence-based information from trusted sources is critical in changing behavior and successfully building vaccine confidence. ANA has a dedicated COVID-19 website, which includes a page for vaccine resources. It is equipped with the latest information from reliable sources such as the CDC. We believe a webinar series and quick videos have been developed about vaccine development and distribution that are geared towards nurses. We've also created guiding principles for nurses on the COVID-19 vaccine, focusing on access, transparency, equity, efficiency, and safety. The aim of these principles is to help nurses and other healthcare professionals examine the considerations of immunizations. ANA has also called for a concerted effort to provide communities of color ongoing information and facts about the COVID-19 vaccines and immunizations. We have seen how the long-standing history of negligence in providing equitable healthcare has eroded trust and ultimately caused communities of colors to be suspicious of the healthcare system. To help address this and decrease the disproportionate COVID-19 infection rates, communities of color must have timely access to credible information about when and how to get vaccinated. ANA urges Black, Latinx, and all nurses of color to connect with their patients, share culturally relevant information, and answer questions your community may have about getting vaccinated against this virus. Nurses serve as role models, and we're learning that people are more willing to get vaccinated if they know someone personally who has received it. We have found that nurses sharing their COVID-19 vaccination experience as a rollout when extreme benefit to building trust and confidence. Personally, I have shared my own experience as a participant in the Moderna phase 3 clinical trial. I chose to participate in part because I recognized the need for more people of color to participate in clinical trials, but also because as a leader, I wanted to stand in solidarity with my colleagues and alleviate any concern or hesitancy surrounding this vaccine. An increased visibility of nurse experts and other healthcare leaders in the media has been a great influencer. Sharing facts about the vaccine, dispelling misconceptions, addressing concerns, and leading by examples has truly solidified these professionals as trusted community resource. I encourage all nurses and all healthcare professionals to review ANA's COVID-19 vaccine educational offering as they seek to become knowledgeable about authorized COVID-19 vaccines and as they consider immunizations for themselves and their families. I believe this is critical for the nursing profession to model the same health maintenance and prevention measures we're advocating for with our patients. It protects the health of the nurse, our patients, and our communities. Thank you, and I look forward to further discussion.
Thank you, Dr. Grant, for your participating in the clinical trial and really leading by example. As a public health person who also is a pediatrician and a mother, I know the important role and power that nurses have in influencing people's opinions in their clinical practices, but also in their community. So thank you so much for this important work. This next question is for Dr. Monica Burrell, Commissioner of the Massachusetts Department of Public Health. Community engagement is another pillar of CDC's confidence strategy. Can you talk about the community engagement activities that are going on in Massachusetts around trust and vaccine confidence?
Yes, thank you so much. First, thank you so much for having me here today to talk a little bit about some of our work in Massachusetts. Our vaccine distribution plan in Massachusetts is based on 3 core principles, and those are preserving life, preserving our healthcare infrastructure, and equity, reaching our hardest hit communities. And when we think about that, this is really in line with our overall approach at the Massachusetts Department of Public Health, which is based on using existing data that we have to highlight the social determinants of health and really hone in on where our data disparities are and target our limited resources to those areas. This data to action approach has really been our health equity approach for the last 6 years at the Massachusetts Department of Public Health and has been the framework for our racial equity work, as well as now our COVID-19 response. And, you know, as we've all mentioned, COVID-19 has put a very harsh spotlight on existing health inequities that many of us, including on this panel and people who are listening, have been working on for a long time. As we started to address the COVID-19 pandemic in May, in Massachusetts, we set up a health equity advisory group. And this is a group drawn from the community with community voice to help us understand how to mitigate COVID-19. They gave us critical information such as where the data gaps are, where we needed to do more work in mitigation work, and now helping us with our vaccine distribution work as well. A key focus of our community engagement efforts in Massachusetts has been around building trust and confidence in the COVID-19 vaccine. And I want to just briefly give you 3 concrete examples of this community engagement work in Massachusetts. First of all, in this fall of 2020, we put into place a community impact survey. And that community impact survey was our attempt to get real-time data, both quantitative and qualitative, from communities that were hardest hit. The important difference with this survey is that we engaged community-based organizations to help us raise the voice of those that we often don't hear about in surveys so that we could overrepresent them. So that included individuals who were from Native American, LGBTQ, non-English speaking, Hispanic, Asian, Black, and disability communities to raise their voice and understand their concern related to accessing testing, delays in healthcare, access to food, housing, et cetera. And we've used the results of that survey to really understand and move forward our programming and our policy work. My second example is related to public campaigning, which we've heard a little bit about today already. Even as we're rolling out the vaccine in limited eligibility, we know that there may be trust and confidence issues. So we have been working with community-based groups, faith-based groups, our healthcare providers, community health centers, and others to understand what are the concerns and what are the barriers so that our public messaging can really be informed by that. So barriers such as short and long-term side effects, lack of trust in pharmaceutical or government, or barriers such as transportation, or having access to information in native languages really informed our campaign, which is called Trust the Facts, Get the Vax. And one of the important things we heard is that this information must come, as we've heard repeatedly, from trusted voices. And what our community groups felt was that the most trusted voice for this kind of vaccine information is from trusted physicians. So the first phase of our group has diverse physicians from different backgrounds in the community sharing these facts and information. And we have an iterative process with our community members in order to do this. My final example is related to a new health equity initiative that we've put in place in 20 cities and towns across Massachusetts in order to increase resources and assistance in those areas. And again, in a data-driven way, those 20 cities and towns came from places in Massachusetts that had the highest COVID-19 burden, that were based on social determinants of health using the CDC's Social Vulnerability Index, and then disproportionately impacts of COVID-19 on Black, Hispanic, and other people of color. Those 20 communities will get a direct connection to the Department of Public Health, and we will go and hear the community voice, because as others have mentioned, it's that unique voice in each community, as opposed to us coming in and saying, here's what we have to offer to you. It's saying, please tell us what you need so that we can uniquely tailor the information and the resources that we're providing you. So using the data and the narrative together. And finally, just to end, as we've all talked about, we all want this pandemic to be in our rearview mirror. And that is going to have to be about efficiently and effectively distributing vaccine. And in Massachusetts, we've worked very hard on the efficiency, and we're actually among states with 5 million individuals or more. We're number one in vaccine allocation per capita. However, we must explicitly tie that to equity so that we're reaching a balance between efficiency and equity. Thank you so much. I look forward to our discussion.
Thank you, Dr. Burrell. Wonderful examples of the work that you're doing. It's really inspiring to hear about how you're using the data to really inform your work, but really at a state level, getting down deep into the communities themselves and listening to them and hearing what their concerns are. Just impressive work. And now I have a question for, or two for Dr. Sybil Madison, who's the Deputy Mayor for Education and Human Services for the City of Chicago. So Dr. Madison, I have the first question for you is, Chicago has a few initiatives to engage community leaders and trusted community messengers around equity, trust, and vaccine confidence. Can you talk about this work and what you're seeing in Chicago?
Sure, thank you, Dr. Morita. And I should say thank you for your service to the city as Commissioner of the Public Health Department. You had mentioned the task being that we have to earn the trust, and I agree. As government, we're starting with a trust deficit. So the work that we've done in Chicago has been about building and rebuilding, earning and re-earning that trust, because you can only move as fast as the speed of trust. I want to talk today about our racial equity rapid response team. Mayor Lightfoot, when we looked at the devastating impact of COVID on Black Chicagoans in particular, in the first month of the pandemic, 75% of the deaths in Chicago were of Black Chicagoans. She immediately set up the Racial Equity Rapid Response Team, which we stood up in partnership with Westside United, an organization that has been working on the west side of Chicago to decrease the life expectancy gap between Black and Latinx Chicagoans and their Chicago peers. That Racial Equity Rapid Response Team brought together not only the mayor's office and our Chief Equity Officer, Candace Moore, our public health department, but also our academic public health partners at University of Illinois at Chicago, hospital providers in the city, our large providers, as well as community leaders from those communities that have been hardest hit. First, those hardest hit with mortality, and then later, Latinx community leaders who were hardest hit and continue to see persistent high case rates. We all sat around a table and developed a strategy together that focused on 4 areas. Education and communication. So taking the general COVID messages and tailoring them to what was needed on the ground. Prevention, making sure that people in the community had access to things like masks and hand sanitizer. Treatment and care, so making sure that our testing resources were going to the communities that needed them the most, but also ensuring that people were getting connected to care through those efforts. And then finally, basic needs. One of the things that our community leaders lifted up immediately was they were just as concerned about food insecurity, housing insecurity, the needs for cash assistance as they were about COVID. So we now in our vaccine work are standing on the shoulders of the work that we've done in COVID. And I think the biggest thing that we've done is that we've kind of flipped the model. So instead of bringing all of those voices to a table set by the city, we now have tables set by community, and we're bringing the resources to those tables. So our community leaders are now setting tables that include other community-based organizations, faith leaders, school leaders, as well as our hospital providers, our FQHCs in particular. And then the city is coming to those tables and focusing on what are the messages that need to be heard in this community? What are the myths that need to be busted? Who are the trusted messengers? And what do they need to share? So we've been in collaboration with our partners hosting town halls where trusted community members can talk about their own vaccine stories and share their testimonies. In that work, we've also been focused on community outreach. So leveraging the strategies that have been used for such a long time by community health workers and promotoras, going door to door, showing up at grocery stores, laundromats, focusing in on where the essential workers are in each community, thinking about the shadow economy and how we get to those who are less connected to major employers. And then finally, strengthening provider partnerships between our community-based organizations and our providers, and ensuring that through those partnerships, those who have not been historically connected to care can now develop relationships with providers, again, especially our federally qualified health centers. So through that work, what we hope is that we will strengthen the community-led and community-based infrastructure needed to continue the ongoing fight against health inequity when we do put COVID-19 in our rearview mirror.
Thanks, Dr. Madison. You know, it's interesting being in Chicago. I've been keeping close track of the vaccine coverage levels by race and ethnicity, and I'm seeing the positive impact of the efforts that you are making. What I love to hear from you talking about too is how you're looking at this work as being foundational to addressing health inequities more broadly. So after the pandemic is over, you'll have this infrastructure in place and these systems in place to actually address other health inequities. So fantastic work, and thank you. I'm also interested in understanding what's happening in the school settings. And I know this has been a contentious issue for you over the past few weeks, but as Deputy Mayor for Education and Human Services, can you talk about the efforts to build trust and vaccine confidence among educators and personnel in school settings, K through 12?
Yeah, there actually is probably more confidence among our educators than we might have expected. You know, our non-public educators here in Chicago have been working since June of last year. So they've been teaching and serving our children in person. And so we have many people who've been anxious to have that additional layer of protection by getting vaccinated. Our focus has really been most recently on all of those educators who are not connected to larger employment systems, so not part of our public education system, not part of our archdiocese system, and making sure that we reach those independent daycare educators, those home-based family daycares. And again, our partnerships with community leaders and community organizations can help us identify those educators who may be harder to find, less visible, because again, they're not connected to our larger systems. So that work has been very grassroots and ground-based, has relied upon really wonderful relationships that we've had with folks like Lurie's Children's Hospital, you know, willing to come into community, do strike teams and vaccine events so that we can reach those educators who are less connected to our bigger systems here in Chicago.
Great, thank you so much. Thank you for all those great stories and insights. Now I'd like to invite you all to respond to a few more questions, including some that we received from participants of today's events. So I'll open up the questions and you can just jump on in and answer as you when you think it's appropriate for you to answer. The first question is, what kinds of key partnerships are required to do this work? And how did you build those partnerships, and how can we foster innovative partnerships to build trust and vaccine confidence? I think Dr. Madison and Dr. Burrell, you've addressed some of this, but if maybe you could go a little bit more deeply into these kinds of relationships and how you actually established them, and if you had them before or if they were all new. I think we'd love to hear about that.
I'll start, Dr. Madison, if that's okay. I think one of the key tools that we can all use is, in fact, leveraging existing relationships. And I think you've heard all of us speak to that a bit. Many of us have existing relationships through other programs and policy work, and using those, because they're many times built on trust and prior relationship, can really help. And we've used that with our community-based organizations, faith-based organizations, community health centers or FQHCs, local boards of health, and through the healthcare system. And that way, you're building on a foundation that's already there and not having to recreate the wheel. And additionally, a lot of us have been working through the COVID mitigation work with a lot of these communities. So it's building on that and then enhancing that work to then talk about vaccination as well.
Yes, the only thing that I would add to what Dr. Burrell was saying is that, we all know that the leaders who've been working in their communities for a long time, they were in their communities before COVID, they'll be in their communities long past COVID. So not hard to identify those partners, and then those partners bring more partners. I think what we've been most excited about are the new relationships that have been developed, or the stronger relationships that have been developed, in our case in particular, between our large hospital providers and our FQHCs. So the relationships between those two groups of entities, as well as stronger relationships between those healthcare providers and our community-based organizers and leaders.
And Dr. Madison, I really like you. Oh, go ahead.
I was just going to ask Dr. Grant or Dr. Smizer if you have any things to contribute.
Yes, I do. I would just like to say, with our key partnerships, one has been our constituent, our State Nurses Association, and individual nurses themselves have been able to provide us with key information, which we have taken and shared that with the government agencies that we have worked with. And one of the things that we're constantly saying is that nurses must be at the table, when, particularly in this case, when, to have a successful partnership in addressing, these issues. So by finding out what is happening at the grassroots level, we can in turn share that with our government agencies, and then, tell them what we're seeing, that is happening, so that they can retool and begin to address those issues as well. And the final thing that we're doing is our foundation, the American Nurses Foundation. We do every other month pulse surveys of nurses as well, and taking that information and sharing that with the government agencies also lets them know, we get a feedback as to how well things are functioning, or if things need to be concentrated in certain particular areas.
I think
That's a great point. Go ahead, Dr. Smizer.
I think all I would add is if you look at the information that does the best, that really resonates with people, it's always the same, and it's not rocket science. It's local and it's personal. Mm-hmm. So if you think about health communication, and if you think of it like there's 12 people involved and they're sitting around a round table, only one of those people should be somebody from public health. And the other 11 people should be people from the community, from all aspects of the community. And they should have an equal say into how things are being communicated, and to whom and when and why. And I have found that to be true every single time we look at this data. We all hear about the fake documentaries and the foreign interference and all that stuff, and that's all real and should be concerning, and public health has to deal with it. But the stories that spread through communities like wildfire are the stories of the nurse who worked a 24-hour shift, and the story of a doctor who is on the edge of burnout, or the teacher who's showing up or is concerned about showing up. It's local and personal, and I just think we need to keep coming back to that again and again and again.
Dr. Burrell, did you have something else to offer?
I just want to say on that point and the point that Dr. Madison was making earlier, this local and personal thing, I think it's such an important thing that we need to emphasize. And I appreciated the way that Dr. Madison framed it about, it's not about us in government or other agencies inviting people to the table, but going to those tables that are already set and really listening and, you know, providing resources, but most importantly, hearing what their unique needs are and allowing the local trusted voice to really carry the message.
Yeah, that's wonderful. I'm so glad you underscored that. I felt the same way when you talked about flipping the model and going to the community tables that were already set. I just love that. And this customization concept as well just really rings true. And then Dr. Grant also, professional organizations are just such key partners with local public and state public health and national public health. It's really, really important for us to be working closely together. So thank you for lifting up these points. Let's see, I'm going to move on to the next question. What role can nonprofits, national organizations, and state and city governments play to increase vaccine confidence? I feel like we've kind of addressed that one already. Is there anything, does anybody want to add anything else to that question? Or if not, I'll move on to the next.
The one thing I would say about that is I think as we're all coming at this from multiple different angles, it's this question of having consistent information and saturating all of these different channels with the same good, consistent facts so that people are hearing it from multiple different places where they might get their information. So I think all of us really being aligned with that is important.
That's so true. I think when I look back at the successful public health interventions that I've experienced in my 20 years in Chicago's Department of Public Health, the best and strongest responses were those where there was federal coordination of the messaging and it was clear and consistent. And then we at the state and local levels could actually customize it to the communities that we serve. So I think that's so, so true. So thank you for lifting that up. Next question is, what have you learned over the last year that will inform your work over the coming months as the vaccine continues to roll out? And so I think that applies to just the vaccine response, but also beyond that. And I think, Dr. Madison, you were kind of alluding to that as you talked about addressing future health inequities. So I'll stop and let you all jump in.
I mean, I think this has already been said, but a key learning has been kind of going to the community table that's there and bringing our resources to that table, you know, following the guidance and direction of those who are more deeply impacted. And that old saying of not for us without us, I think has been tried and true during COVID and will be something that we continue to organize around as we move forward.
I would also just emphasize that science matters. One of the things that we have learned over the last year is that science matters, and that, you know, we have to have trusted evidence-based information that matters. And I would also say being transparent, you know, and accurate also is expected. That's a way to continue to earn trust, and, you know, we have to keep remembering that, and, you know, and going back and re-emphasizing that as we learn more and more, not only about, you know, still learning more and more about the virus every day, but then also just, you know, human interaction and, you know, and their perception of things as well. So, you know, we definitely need to continue to readdress those issues.
I think there's so many lessons. I agree with echo both of those sentiments. There's so many lessons we've learned, and so much we need to not forget to honor those that we've lost as we move forward with this. And I think when you get down to it, it's just how at a global level we're all interconnected, and that when we do health equity work improves health for all of us. So as we move forward using these foundations that have been built and this work that's occurring to make sure that we continue with that forward is going to be really important.
I think for me, well, 2020 felt like it was like a decade. So I agree. So many things learned, so many painful lessons. I think for me, from where I sit, it's that the identification and tracking and responding to misinformation is actually the job of public health. We were caught unprepared. I think for everyone would agree. And I think when World Health Organization declared an infodemic, that was a wake-up call for a lot of us. But I think that responding is really the beginning of the work. as we know in public health, just sharing data with people does very little. It needs to come with guidance and an understanding of best practices and best evidence. Who does that information go to, and what do they do with it? And how is it a partnership, not a unidirectional flow of information? That's a trap we sometimes fall into in public health, where we build a nice disease surveillance system and then nobody uses it. So I think that's our work moving forward in 2021 is if you look at most local health departments, they're lucky if they have a single PIO, a single public information officer, and that person has 1,000 jobs. And public health is already stretched super thin to the point of breaking in a lot of places. So it's one more thing we need to do. But I think we've seen the impact of what happens when there is a void. It gets filled, and not always with the best stuff. So I think for me, that's it.
It's important lessons to share. I think, to me, one of the things I watched as this response has played out, just watching Chicago and how you've leveraged the community relationships that you had established over the course of time before the pandemic to really rely on those relationships to help you move forward over time has really been important. And so I'm keeping my fingers crossed that as more of these relationships are being established throughout the nation, that we really look to these relationships to leverage work as we move forward regarding other health issues, whether it's substance use disorder, mental illness, mental health, chronic diseases like diabetes, hypertension, cardiovascular disease. These are the kinds of these relationships and these methods of communication can benefit us all beyond the pandemic when we think about health inequities in particular. So just so grateful for you all that you're doing all the work that you're doing, but also hoping that we can leverage that as we move forward. That is not the concluding question, though. I just had this feeling and had to say that. So I'm going to now move on to the next question for you all. The next question is a participant question, and it's from Carly from Kansas. What are some key non-public health voices that we should be empowering to address vaccine confidence? So I guess what I'd be interested in is specific examples, because you've raised up this, everybody's kind of mentioned this need to have non-traditional people speaking out, but can you give examples of those that you feel are most successful or most impactful within your communities and the work that you're doing?
Well, I'll say we've been doing quite a few town halls in partnership with community leaders, and we had one just on Saturday. And we had someone just who lives in that community talk about her vaccine story and her testimonial around it. And she talked about, her journey towards confidence and all the reasons why she decided to get vaccinated. And of course, talked about that experience and what came afterwards. In these town halls, we've also found it really important to have very hyper-local doctors and other nurses, medical professionals who work in that community, are known in the community. So those are public, I guess, non-government public health voices though, who are neighbors. And then finally, faith leaders have been tremendously involved in this work. And as everybody knows, have powerful voices, not just on Sundays. And so it's been really important to be engaged with our faith leaders.
I would just add to that in our work that also has focused on, town halls and those larger forums, but also smaller groups of community members coming together. What we've provided as a resource from the State Department of Public Health is, basically a framework of what the facts are, so that we are providing the information so they don't have to do all that background research. And again, having consistent messaging, and then the voice with which it's heard is that local community point, to your point, Dr. Madison, to make sure that really they're hearing from local leaders. I will also say that, part of this approach that's been really wonderful to watch is that we often do interact, as Dr. Morita, you said, with these different organizations, but it's not often that we're interacting with them together, where we're all at the table at the same time. So it's the, senior services, the Immigration Assistance Center, the homeless shelter colleagues, the neighborhood associations, and we're all talking together about addressing the problem. And that's really powerful to watch as well.
I think one other group that we perhaps, and I think it was mentioned previously, is the local barbershop and the beauty parlor. Or the nail salon, because you've got a captive audience. And I hate to use that term, but if you've got someone who's if they're getting a perm, however long it may take to get a perm, maybe 2 or 3 hours or so, educate that that beauty operator or that barbershop owner to of all the things that they need to do. And believe me, they are definitely trusted people, because obviously you're going to trust that person with your hair, the way you look, your nails, and and everything else. So that's a great way to help get that message across as well, because you've already got that established trust. If that's been a long-term clientele that's been coming to that person for years and years and years. And we know from other studies, such as looking at breast cancer or talking about HIV or men's health, that that definitely does work in those particular settings.
I think all I would add is everybody has a voice, and what they do with that voice really matters. And I don't think you need to be a health professional to be involved and make a big difference here. I think a lot of us have been sitting around in a tiny apartment or in our home, seeing the same faces every day and the same four walls every day for the last year. And we want to get involved and want to do something, want to help. And this is a way that everybody can help. I don't think you need to be a public health doctor or medical doctor. I think maybe the role of public health is to help people know what truth is. And then we need to be really comfortable letting everybody be part of the conversation and not be so concerned whether they're saying things exactly the same way we would choose to say something. That's just not that important right now. I think loosening the reins, being a member of the conversation, just one voice in a chorus, whatever metaphor you want to use. But I think I'm looking forward to seeing that happen this year.
That's great. It's good advice for home as well. I'm just thinking I need to let my kids do a little more talking at home and listening to them a little bit better. Let's see. So the next question I want to ask is another participant question. Monica from California. How do you build trust when there's a lack of access to vaccine in the community?
I can start with that. One of the points that I raised in my introductory comments was about making sure that we have efficient and effective vaccine distribution, as well as an explicit focus on equity. And, I think as we're working with communities, we're finding that, of course, they want to work to build trust and confidence, but they are also saying that in the places that vaccine is accessible, we want to make sure that our community members can get to that as well. So we really want to work with them to understand, for those who are eligible, how can we also, I think it's really important that we listen and partner on making access easier. So for example, if the issue is not understanding where the sites are and needing that information in native languages, we can put that out in the information that way. Or if it's about transportation, working to streamline our transportation options to get to these vaccine sites. So I really think that communities are speaking up loud and clear that we have to address both at the same time, because they're both equally important.
Yeah, in Chicago, our Protect Chicago Plus strategy focuses on 15 of the communities that have experienced a high burden during COVID. And so we're starting with the 15, we'll keep going. But in those 15 communities, we are setting up temporary vaccine clinics and also doing kind of mobile or strike team vaccine events, so that when we partner with community members and then get the word out and try to build the confidence, we actually can say, and you can go to the clinic right here in your community. And we've been working really closely with our local FQHCs and community leaders to figure out the best strategies within each community to then make sure that those who live in the community have access.
Any other comments? Dr. Grant, Dr. Smyser?
I think the two comments that were made covers it all.
Yeah, and one thing I would maybe add to that, their comments, is that I think in the times when there's a shortage of vaccine, as supplies are limited, there is people are anxious and they're concerned. And so being as transparent about the supply issues, or what is known or what is not known, can really help to build confidence or earn confidence from the public. Because I think if people feel like we're hiding things or we're not being completely honest about things, then there's less likely to be the trust and confidence that we need, whether it's supply or whether it's about the safety of the vaccine or how effective it is. I think this transparency is key. You've all mentioned the importance of that, but I think in particular during a time where there is a small supply or limited supply of vaccine, it's really important to be transparent about those things. So I think that's what I would add.
Just to add on some of the, I was raised in California, and that will be relevant in a second. One of the best crisis communicators I've ever encountered are fire captains during large fires. They have the trust of the public, and they very transparently and matter-of-factly explain the path of the fire and what they know and what they don't know. And they're giving constant updates all day, every day. And I think we in public health could learn a lot from other fields that are very skilled, because they have to do this all the time, and how to communicate transparently and not lose the trust when you say that you don't know, or that you don't know what's going to happen tomorrow or next week, but to be able to do that with authority in a legitimate manner. I think there's a lot of things that we're getting better at as we go over the course of this pandemic.
That's a great point. Just taking advantage of people and learning from others who have far more experience in these areas is really a wonderful idea and something we should take to heart. So this is my last question for you all as a group. I think maybe the key thing is really, what are the key points that you would want the audience at large to remember? So we'll go around the room and you can actually just give maybe the top couple ideas or key points that you really want the group to actually walk away with from your experiences. So I'll just stop, and maybe Dr. Burrell, you could start off with us first.
Sure, absolutely. First, I really want to appreciate everybody who's listened in, because it shows a great desire to improve trust and confidence in the vaccine. And I would say, first of all, thank you for all the sacrifices everybody has made over the last year. Trust and confidence in vaccine is work that we can all do. And so I would say wherever you sit, whether it's talking to your family members, talking to your communities at an association level, running an organization, a nonprofit, being in healthcare, wherever we are, we have a role to play in helping distribute accurate information. And then I also would add that, really making health equity explicitly part of plans is really critical, because again, when we address health equity, we improve health for all of us.
Dr. Madison?
Yeah, I guess I'm thinking about two things. One, just keep it hyper-local. Keep it hyper-local, and partner with those who can help you keep it hyper-local. And then the second thing I would say is just the work that we're doing now. These are the building blocks for transformative work moving forward. So all of these relationships, longstanding and new, we should think about the ways that we can sustain them, so that we can keep working on all the inequities that we have in health in our community.
Great. Dr. Grant?
Just very quickly, I guess, to piggyback on what Dr. Madison has said is, essentially knowing your audience, how they get and receive information and digest it. In other words, meet them where they are at, and not necessarily, try to push through what we feel that they should, that they should have. And I guess the final thing is, of course, making certain that we do maintain transparency at every angle.
And last but not least, Dr. Smyser.
I just always remind myself that what is powerful about public health is the people, and that's what public health is about. It's about the public. It's about communities, and and anytime you work with people, it's messy and complicated, but it's also inspiring and wonderful, and that's how real change happens. And so I think that this pandemic, I really hope it enables us to build back better. And that building back better is I think going to be manifest in a lot of ways. But in our field, I hope it's that we really deepen ties to communities and open up those dialogues in ways we haven't before. And we address in real substantive ways structural racism. And I hope that when it comes to misinformation, that we figure out as a community of health practitioners how we deal with this, because it's certainly not going away.
Wow, thank you all so much for your comments. It was just a pleasure joining you in this discussion. I've learned so much, and I feel your passion and your commitment to these areas. For me, I will just take the opportunity, since I am the moderator and I get to wrap things up and maybe give you my key takeaways. And the first I would say is really it's important to earn trust through clear and transparent communication. And then also identifying and elevating trusted voices around vaccination, including those outside of public health. That message has come through so incredibly clearly through your comments today. And then working really hard to combat misinformation in creative ways. That has really has resonated through all of your comments and remarks. And then each one of you, even though you weren't asked to talk about healthcare personnel, each of you talked about how you work with healthcare personnel to really convey these important messages and to earn the trust of our communities. And so I think that's really important as well. And then lastly, really engaging communities and individuals in the decision-making, planning, and also implementation. So we're no longer about just talking about getting information to the community. It's really about working with the community to listen to them and also understand what they believe are the solutions and what they want to do to address the problems. So all those messages really came through so strongly through your comments and your remarks. So thank you so much for all the information you shared with me and with everybody else who was listening. I think this was really just an incredible conversation. And I think there's a lot of work that we have that lies ahead of us. But because of your knowledge, experience, willingness to share, and all the people who are participating who want to learn and do and implement to make it better for our country, I thank you and I thank the audience for all that they will do over the coming months to protect our nation and our communities. And I'll turn it back over to Dr. LaBerge. Thanks, everyone.
Thank you.
Thank you.
Thank you, Dr. Morita, and to all of the panelists. We have had a rich exchange of information, expertise, and experiences, and all intended to build trust and confidence in COVID-19 vaccine, as well as in the public health enterprise more broadly. Our mission, for those of us who have committed our lives to public health, is to promote and protect the nation's health by all available means. Knowledge continues to be power, and working together, we can end this pandemic. Before we wrap up this plenary, I would like to share our sincerest appreciation to the incredible people and organizations working tirelessly to implement COVID-19 vaccination across the U.S. A special shout out goes to two organizations focused on ensuring that Black and Hispanic and Latino communities will get vaccinated. We send a shout out to Choose Healthy Life, an organization that has galvanized Black churches across the country to address mistrust, as well as provide access to COVID-19 testing and address health disparities. The National Hispanic Medical Association, we send another shout out because they continue to be a trusted voice for medical providers by developing education campaigns and providing resources for their members across the country to support COVID-19 vaccine uptake. They and so many others around the country exemplify what it means to come together as a nation and play a part in this process. And so I encourage all of you to think about what role you and your organization might play. So together we can reach our goals and help bring this pandemic to an end. Thank you again for joining us, and we look forward to engaging with you throughout the National Forum on COVID-19 vaccine.